Alright, so welcome to Road to 250. We're going to cover various topics today, including Haemophilus influenza, heart failure. So I'm going to mostly focus on pathophysiology today because I realize that the topic is really big, and if I try to fit everything into one, I would take up a lot of time. And then we're going to do some inotropes as drugs for today. So let's get right into it. Haemophilus influenza. Can you guys tell me the shape of this bug? Or
geomorphic? Rod?
So I'm looking for, like, is it a rod, a bacilli? Is it gram-positive, gram-negative?
Rod?
Yeah, it's a rod. Is it gram-positive or gram-negative?
Gram-negative?
Yep, so it's a gram-negative bacteria. Has a cocobacillary shape, or it's also known as a rod. So what is special about Haemophilus influenza as far as the agar that's used to culture it?
Blood agar?
No. Unless they have a different name and I missed it. I'm looking for chocolate agar. And they contain factor 5 and factor 10. So factor 5 is where you're going to get the NAD+, and factor 10 is where you're going to get hematin for growth. So where else can you get factor 5 from? What other bug can you also grow Haemophilus with? So it can be grown with Staph aureus, which is another bug that can provide the factor 5 via hemolysis of RBCs. Does anybody know what the mode of transmission is?
Aerosol?
Yes, transmitted via aerosol transmission. Yeah. All right. So, this is just like general stuff. There are 6 identifiable types of Haemophilus, and there are other non-identifiable types of Haemophilus. So the most common that people are familiar with is H. influenza type B. These bacteria live in the nose and the throat and usually cause no harm. However, the bacteria can sometimes move to other parts of the body and cause infections. And these are called invasive or considered invasive, and they can be very serious and sometimes deadly. So the incubation period between these is not really certain, but it could be as short as a few days. So here you could look at how gram staining techniques, what it would look like, and then Haemophilus type B under CSF. Just general stuff for this slide. So we're going to talk about some infections that are caused by these. They can range from mild ear infections to severe diseases. And when the bacterium-based part of the body, they're normally free from germs, like spinal fluid or blood. And these are known as invasive diseases, and they're often severe and result in death. So could you guys name me some invasive diseases that H. influenza causes?
Pneumonia.
Wow, right down the list.
Meningitis?
Okay, that's not right down the list, but that is another one, correct? Epiglottitis, yes.
You mean like mumps? Meningitis, otitis media?
Yes. So the other ones are bacteremia, meningitis. These are only when the capsule form of the bacteria, so it's only type B. And epiglottitis, as Pete mentioned. So this is going to get an inflamed epiglottis, inspiratory stridor, drooling, and then you're going to see this cherry red epiglottis in children, and you can also see a thumb sign in X-ray. So these pictures came directly from first aid. And cellulitis and infectious arthritis are some, but they can also be cause of common ear infections. As Lucy mentioned, you can get otitis media from this as well. So, I mean, we've covered pretty much a lot of this stuff in first aid, but we haven't covered treatment. So, could you guys give me the treatment if it was just a mucosal infection?
Not penicillin?
Try again.
Azithromycin.
So, just for mucosal, it's going to be amoxicillin plus clavulanic acid, plus or minus. And how about for meningitis? What drug would you give?
Ceftriaxone.
And what would you treat prophylaxisly for a close contact? What drug? Rifampin. All right, and there is also a vaccine that you can get which only contains type B capsule of polysaccharides, and it's conjugated to diphtheria toxin and other proteins. So it's given between 2 and 18 months of age. And if Pete wants to add any details regarding that, welcome to. As far as the vaccine.
There's plenty about flu vaccine. That could be a whole other thing.
All right. So we'll leave that for another day. So any questions regarding H influenza? Sorry, I try to keep it as short and sweet as possible.
Okay.
All right. So moving on, we're going to talk about heart failure. So, basics of heart failure. In a nutshell, it's the impaired ability for the heart to pump blood. So you're going to see low cardiac output. So let's look at a basic model. So we have a pump that's basically connected to a tank that has water. And this pipe constantly increases water. But what this pump is doing is pushing out the water as the water is coming in. So it makes sense. If this pump runs efficiently, you're not going to have an increased amount of water. However, let me just figure out the size. I don't think I can change the size. But as this water increases, why? Because this pump starts failing, you're going to have decreased amount of fluid that's getting pushed out at a time. So this water level is going to start increasing. And then over time, it's going to start spewing out. Right? So it's going to start leaking. So this is just a very simple model, and we can look at it for the heart. So heart is pumping blood all the time. However, if it starts failing, everything that's going to back up to, instead of a tank, we're looking at the lungs and veins, and that's going to start leaking. So in a simplistic model, this is what's wrong. The heart isn't pushing enough blood out, and it's going to start backing up. So any questions about that? Sorry, I just get my stuff open. So let's look at the pathophysiology. So when the pressure rises in a cardiac chamber, so let's start in the case of left ventricular failure, you get an increased left ventricular pressure. So what happens is the left ventricular systolic pressure depends on contractility. However, what we're talking about is left ventricular and diastolic pressure. So it's always going to be high in left heart failure. So systolic heart failure, you're going to see less blood is being pumped out, so more blood is being left behind, and thus you're going to increase your pressure. So I'm giving you guys generic information now, and then as we're going through these slides, we're going to kind of break it all down, and hopefully at the end of this, you'll make sense as to what's going on. And in diastolic heart failure, you're looking at stiff ventricles, thus causing too high pressures. So in left ventricular end diastolic pressure, if that increases, it causes an elevated left atrial pressure, because the elevated end diastolic pressure causes the mitral valve to close early before the atrium has emptied. And I have a picture to help you understand this. Next slide. So the increased left atrial pressure causes the pulmonary capillary pressures to increase, and thus causing the symptoms of dyspnea and pulmonary edema. So before I go any further, let me try to explain this. So here, typically, you're going to have left atrial pressure is the dotted line right here, and left ventricular pressure is your solid line right here. So as you can see, they're all kind of together at the end, right? So if your left ventricular diastolic pressure increases, here's your mitral valve closure. So this is where your left ventricular, if this pressure increases right here, it's going to cause the left atrial pressure to also rise with it. So when these two things rise, it's causing issues. Does that make sense?
If they rise together, you're saying.
Yes. If they rise, well, one is going to essentially cause the other to go up with it, because they're always kind of together. So you need this pressure to go up in order to open the aortic valve, if I'm correct, to allow the blood to flow through. So, but I'm saying in a heart failure patient, if this pressure rises above the normal, like let's say the normal is 10 for left atrial pressure and left ventricular and diastolic pressure. Now, if that rises to 30 as an initial one, the left atrial pressure will also initially rise to 30. So that is basically what's causing it to have a problem. That kind of makes sense, or no?
Yep.
Yeah, and then that's going to cause the mitral valve to close earlier and before the atrium has emptied. So that's it's going to cause symptoms of dyspnea and pulmonary edema. And I'll tell you why it causes in a few seconds. Okay, so let me actually just do it now. All right, so and so what I'm going to draw here is a capillary real fast. So stay with me for 1 second. So your blood normally comes in from the right side, right? So the right heart, it's going to go through the pulmonary arteries, and then it's going to come through the pulmonary veins to the left side, to the left atrium. So if I increase my pressure in the left atrium, what's going to happen?
There's going to be more difficulty of the right atrium to, or the right side of the heart to
push blood through.
Yeah.
So the blood will start retrograding backwards, right? So it's going to start building up eventually in the back. So what is in the capillaries? What is essentially dealing with the pressure is your hydrostatic pressure. So here, this is comparing your left atrial pressure. So it's kind of going to be similar for the blood to continue passing through. So if my left atrial pressure is 5, this hydrostatic pressure, capillary pressure, is also going to be 5. So this allows the blood to continue flowing through. Now, in the event that the left atrium starts having issues and the pressure rises to 20, the pulmonary capillary pressure will also rise to 20, and a lot of your blood is going to start leaking out. It's forced out. So this is the reason why you're going to see dyspnea and pulmonary edema, because as the blood is having a hard time coming through, the pressure also rises, causing it to leak out. In a nutshell, if that makes sense.
You're going to have increased capillary permeability with increased pressure.
Yep. So if you continue the pulmonary capillary pressure, so as Pete said, everything is going to start going backwards. So your pulmonary artery pressure is going to increase. Your right ventricular pressure is going to increase. Your right atrial pressure is going to increase. So your right atrial pressure is equal to your central venous pressure. So high pressures in the venous system will cause what to see in a patient? What would you see in a patient if you have a high venous pressure?
Edema.
Increase intracranial pressure.
So yeah, you're going to see the jugular venous pressure, so JVP. So the neck veins are going to come, and then pitting edema, and the capillary will start leaking. So those are why you're going to see all the signs and symptoms of heart failure. Does that make sense?
Just the system's backing up?
Yep, essentially, yeah, and that's causing a lot of these issues. So let's talk about generally when you're laying flat. What is happening? So when you're laying flat, your heart is parallel with your feet, right? So when you're doing that, your venous return is increased from your feet. So the blood is redistributed from your lower extremities to your lungs. Normally, you would not see any effect in a normal patient. But patients who have heart failure, they cannot tolerate these changes. So they will lead to symptoms. And these symptoms, so let's talk about left heart failure specifically. We'll switch to the right heart failure. So in left heart, you have an increase in left atrium pressure and ventricular pressure. So what kind of symptoms would you see in left heart failure?
Respiratory
Dyspnea?
distress.
Dyspnea. Sorry, somebody said something else.
Oh, pretty much the same thing. I just said respiratory distress. But...
Okay, so you also see
Yeah.
orthopnea and paroxysmal nocturnal dyspnea. So these are the symptoms that you would see as far as left heart failure. Now, what would you see in right heart failure when you have an increase in right atrial pressure and right ventricular pressure?
Nutmeg liver.
Nutmeg liver
JVP increase.
and peripheral edema or pitting edema. Cool. All right, so let me ask you a question. What's the most common cause of right heart failure?
Pulmonary.
Left heart failure. That's correct. So, however, right heart failure can occur on its own. So in these conditions, it's where your pulmonary artery pressure or your right ventricular pressure or your right atrial pressures are high, but your left atrial pressures are normal. And these are usually seen in secondary conditions such as COPD and pulmonary hypertension. Do you know what this is called?
Cor pulmonale.
Correct. It's called cor pulmonale. All right, so we're going to come back to pathophysiology in a real short bit, but we're going to talk about some lung findings and histology because that's also clearly important. So on the lung findings, you're going to hear rales, and that's because your fluid-filled alveoli is usually pop during inspiration, and your chest x-ray will show congestion. So normally your chest x-ray, you want to see it completely darkened, but here you can see that there's a lot of white all over x-ray, so that's congestion that you're looking at. And on histology, you're seeing hemosiderin iron-laden macrophages, and these guys, all the brown pigmented stuff here. So these are heart failure cells, as they call it. So, and then we're gonna talk about pitting edema real fast, and that's, as you all kind of have mentioned throughout, that it's due to the increased capillary hydrostatic pressure, and the fluid would leak from the capillary to the tissues, and then gravity essentially just takes it down to the lower extremities. And then the heart sounds. What heart sounds would you associate with the high left atrial pressure?
S4. Oh no, that's not compliant.
It's S3. So the heart is failing. And which heart sounds associated with a stiff left ventricle?
S4.
That's S4. So stiff is usually seen in a diastolic heart failure. All right, so we're going to come back to pathophysiology. As quick as that. Sorry. I'm getting ahead of myself. So what happens when you have a decreased cardiac output? Because in heart failure, the biggest thing that you're going to see is a decreased cardiac output. So what systems are getting activated to push the cardiac output? when you see it low.
Vascular resistance will decrease?
It would increase, and I'll explain why. But I was talking about your sympathetic nervous system and renin-angiotensin-aldosterone system. So these two systems will get activated because it senses a low cardiac output. So it's kind of contracting, trying to contract. So the effect of these two systems is to increase peripheral vascular resistance. So you want to vasoconstrict. And you also want to retain your sodium and water by the kidneys through the renin-aldosterone system. So from what I've understood, TPR is always going to be high in heart failure patients. So if I remember correctly, blood pressure is equal to cardiac output times TPR. Or is it backwards? I think it's cardiac output times blood pressure times TPR. So generally it's this one of these formulas, and TPR is always supposed to be high in heart failure patients, but necessarily, it is. Blood pressure doesn't have to be down, but it can be down. But I guess this will kind of help you. So when your cardiac output is low, this is from First Aid, page 298. When your cardiac output is low, you're going to activate your renin-angiotensin-aldosterone system. So obviously, you're going to reabsorb your sodium and water, and that causes your systemic venous pressure to increase and can cause peripheral edema. Or your sympathetic tone will increase your contractility, and that will increase your preload and cardiac output. So it's compensating for the decreased cardiac output. But again, all of this doesn't necessarily mean good things, because what does having a lot of fluid mean? You're going to see more edema, but that is due to these systems being activated. So there are other hormones that are in the body that are trying to basically counteract the renin-aldosterone system. Do you guys know which hormone? Never mind, I kind of gave it away. But which hormones released by the atrial myocytes?
Natriuretic peptide.
ANP.
ANP. So ANP will be released with atrial stretch, so either increased pressure or volume, and it acts via the CGMP. What is the function of ANP?
Doesn't it prevent sodium from being reabsorbed in the distal convoluted tubule?
Correct. And it causes vasodilation. Do you know how it does that in the renal system? I kind of gave you this clue right here to help you. So it dilates your efferent arterioles and constricts your, or afferent arteriole dilates it and constricts your efferent arterioles. So that promotes diuresis. So essentially, in a nutshell, and color, I want it red. If you constrict this and you're going to open this, you're going to get more blood flow to come here. And that's going to help promote a lot of diuresis. So that's the whole mechanism. So it's going to open the afferent side and constrict the efferent side to allow a lot more, less sodium reabsorption. So, sorry, Jack, any questions on that?
No. I'm just saying, okay, good.
All right, so what hormones released from the ventricular myocytes? BNP, or B-type, brain natriuretic peptide. I think there's an MBME question in one of the older forums that they had online about this question. So it has a similar action to ANP, but has a longer half-life. So when you do a blood test in a heart failure patient, you're going to look for BNP because those levels will be elevated in patients with heart failure. It has the same kind of mechanism to ANP. So it's similar in how it functions. What is a recombinant form of BNP? It was used, or it's still used, to treat heart failure. Starts with an N. Nicertide. And
that one.
it's a vasodilator. It decreases your afterload and increases your cardiac output. All right, so let's look at systolic dysfunction versus diastolic dysfunction, or systolic heart failure versus diastolic heart failure. So let's start with something simple. Which one would you see a reduced ejection fraction? In systolic or diastolic?
Systolic?
Systolic?
Yes. Systolic has a reduced ejection fraction and diastolic has a normal ejection fraction. And then another way you can differentiate systolic versus diastolic is the low flow symptoms. So what I mean by low flow symptoms, and these are only seen in systolic heart failure, is when your left ventricular ejection fraction is severely reduced, you're going to see symptoms such as cool extremities, confusion, and like weight loss and muscle loss. So dilated cardiomyopathy. Why do I bring this one up here? So this is a systolic heart failure with the left ventricular dilation. So what type of hypertrophy occurs? Well, I gave you the answer again. Eccentric hypertrophy. So what is eccentric hypertrophy?
When the muscle hypertrophy is due to pushing more fluid over a period of time.
Okay, so it's a volume overload. So the muscle is getting bigger. How are the sarcomeres aligned in here? Sarcomeres, sorry, not sarcomeres, sarcomeres. So they're going to be added in series. So that's the key thing. So let's look at a picture, and hopefully this will help you. So normal left ventricle size, obviously it's this. And when you dilate it, you're not necessarily increasing the width of the myocardium or the wall of the myocyte. So what you're doing is you're adding myocytes in series, so it's getting bigger, but the wall thickness remains the same. So this wall thickness is roughly the same as this wall thickness. So that's the biggest difference in this one. So when you see a systolic dysfunction, you're going to think of like dilated cardiomyopathy. So, or MI, ischemic MI, or dilated cardiomyopathy is what you're going to see in systolic dysfunction. In concentric hypertrophy, what happens?
The sarcomeres line up in parallel.
Correct.
Due to heart is having difficulty pushing through a high pressure system, so systemic vascular resistance is pushing against.
Yeah, so you have a pressure overload causes a decrease in compliance, and this is often seen in diastolic dysfunction. So in this case, you're going to have a normal left ventricle size here, but in here, the pressure is so high that it basically increases the wall thickness, and that's due to concentric hypertrophy. And different diseases have concentric hypertrophy. So can you give me two diseases where you would see this? This is normally seen with diastolic dysfunction. So where would you see this? In cardiomyopathies, if you want to continue that.
Aortic stenosis?
Okay. I'm thinking more hypertrophic cardiomyopathy, or I think also restrictive or infiltrative cardiomyopathy. So I think one example that I learned, which I'm not covering today because that's just a lot of information, but one thing that I learned for restrictive, like amyloidosis, what happens is it's basically adding the wall thickness through amyloid proteins. So that's why you're seeing this wall thickness increase, if that makes sense.
Yeah.
So you could think of diseases like restrictive cardiomyopathies, which has a ton of different diseases that can cause restrictive cardiomyopathies, but and hypertrophic. But these will also always be seen with diastolic dysfunction, and that's you want to think of this. So I guess I had that question right here. All right, so let's look at a pressure volume loop of systolic versus diastolic. So we're going to go through these in detail in the next two slides, but I just wanted you to see, compare and contrast real fast. So in systolic, it's usually because your contractility is down, while in diastolic, you're mostly concerned about your compliance. And lusotropy is essentially how I think your muscle can stretch. So in this one, it's not really being able to stretch. And I'll go through this in detail in the next two slides. So in systolic dysfunction, you have a decrease in cardiac output. So the problem is in systole. The fall in contractility is not allowing the blood to get out. So what is happening? It's decreasing your stroke volume. Now, how do we measure stroke volume on this kind of pressure volume loops? You're going to look at this difference between here. So you could tell between the blue one, which is normal, and the red, which is the systolic dysfunction, that there is a decrease in stroke volume. And that is because stroke volume is measured as end diastolic volume versus end systolic volume. So since contractility is already down, there's going to be a greater end systolic volume. So if this is your end systolic volume, in a normal patient, as you can see here, your end systolic volume starts right here. So there is a higher end systolic volume. However, you also have a greater end diastolic volume because you're not able to get the blood out, and so you have a higher end diastolic volume. But your end systolic volume is much more greater. But the biggest difference here is, look at this end systolic volume, or in this case, I'm comparing the end diastolic pressure. Left ventricular end diastolic pressure is normally right here, right? So here I'm already increasing the pressure that it starts a little bit higher. So I'm increasing the left ventricular end diastolic pressure. But the biggest takeaway you want to take from here is stroke volume is down because you have end systolic volume is up, and you also have a greater end diastolic volume. Does that make sense? Sorry, I kind of spoke a lot of gibberish. Oh, sorry, your left ventricular end diastolic pressure is right here. So this is higher than, let's say, a normal patient who had it right here. So you see the pressure increase slight bit, but it's still higher.
Okay, so you have so in the systolic heart failure, you have decreased contractility, so the heart is not pumping as well. So your end systolic volume is going to be increased because at the end of, you have a larger volume remaining still in the ventricle, right?
Correct. Yeah, because you can't get the blood to get out.
And so the end diastolic volume on the other side is is increased because it's got backup and it's got to take all the blood that's rushing in anyways.
Yeah, so I think end diastolic volume is your ESV plus venous return. So you still have venous return coming in, but you also have a greater amount of end systolic volume inside. So that's the equation for end diastolic volume, ESV plus VR.
So you can kind of think of it like that I Love Lucy episode where they like screw up one thing on the conveyor belt, like it keeps coming in because they keep getting backed up, and the conveyor belt just keeps backing up and backing up.
Right. Yeah. So since this is going to be high, your end diastolic volume is already going to be high because this is high. And then you still have venous return that's still coming in. So that's why this pressure kind of shifts to the right. Does that make sense?
Yes.
All right. So in diastolic dysfunction, your problems with your diastole, you still have a low cardiac output as in any heart failure, but you can't get blood in. So you have a slightly smaller stroke volume. Now, from what I've learned, they can also see a slightly smaller end diastolic volume, but first aid says that you could also see a normal end diastolic volume. So in diastolic dysfunction, take it as you're going to see slight decrease of end diastolic volume or normal end diastolic volume, but it's going to remain the same. The biggest thing that you want to take from here is this. Your pressure is shifting to the left, so you're going to have left ventricular end diastolic pressure, which is right here, is higher. So you have a high pressure because you have a stiff ventricle, and that's why you can't get blood to come in. So that's the biggest takeaway from this thing. And you have a decrease in compliance. So you don't have a problem with contractility. You're still contracting normally. That's why your stroke volume is roughly the same. But you're decreasing in compliance, and thus it's causing to have a stiff. That's because of the stiff ventricle, in simplest terms. So any questions with this one? Okay. So if no questions, we'll move to inotropes as the drugs for the day. So what are inotropes?
Drugs that increase cardiac contraction?
Correct. So they're used in systolic heart failure since contractility is normal in diastolic heart failure. So you're mostly going to use these drugs for systolic heart failure patients. So what effects do inotropes have on beta 1? Pete kind of gave it away. They activate the beta 1 pathway, thus increasing heart rate and contractility, but they can also have an effect on beta 2 pathways in the smooth muscles, leading to vasodilation and hypotension. So not only do they work on beta 1, but they also work on beta 2. Can you list some inotropes?
Digoxin.
Digoxin is one.
Catecholamines?
Sorry?
Catecholamines?
Like epinephrine?
Mm-hmm.
Yeah, epinephrine is another inotrope. But we're gonna focus on the top 2 for today. Sorry, I didn't want to overdo it, but there's a lot more other ones. But dopamine, digoxin, noradrenone, and dobutamine. And then epinephrine is another one that's just not listed on this list. So let's do a quick review of 2 of those. So let's start with milrinone. What is milrinone's mechanism of action?
It's a phosphodiesterase inhibitor.
Yes, they're phosphodiesterase 3 inhibitor, but they're selective for these ones. So what is the normal function of phosphodiesterase 3 in a cardiomyocyte or anywhere in the cell or in the body?
It breaks down
CAMP. So phosphodiesterase 3 breaks down CAMP. So by inhibiting it, it causes an increase in CAMP and increase in calcium influx, thus contraction. And this is specifically in the cardiomyocyte. So what happens in the smooth muscle if you increase CAMP?
Contraction.
So it's going to vasodilate. Because by increasing
muscle.
CAMP, you're going to inhibit the myosin light chain kinase and thus cause vasodilation. So these are good. This drug is good for short-term use in acute heart failure, but definitely not chronic. Do you know any ADRs for this one? Let me highlight something, maybe help you.
Low blood pressure.
Correct. And arrhythmias is the other one, which I'm assuming because you're increasing contractions, you can possibly cause arrhythmias, if I had to associate, and then hypotension because you vasodilate. And one other one is dobutamine. What is dobutamine?
Beta 1 and beta 2.
Right. But which one does it have a greater effect on?
Beta 1.
Yeah. So it's a beta 1 greater than beta 2, and it's a beta 1 agonist or beta 2 agonist. So again, beta 1 increases your heart rate and contractility and has a weak beta 2 effect, which is going to cause vasodilation. And I think in first aid, it also has some alpha effect, but it's nothing too great. What are the ADRs for this one? Not sure if it's listed anywhere, but again, you can think of hypotension as the one that I always figure because of vasodilation. And clinical applications for dobutamine, heart failure medication, or it can be used in cardiac stress testing. So that's another way that they could ask me that question. So I really just wanted to cover this, and then I have one more slide after this. But I found this to be somewhat helpful in acute heart failure. I only covered the inotropes, but you could use nitroglycerin and loop diuretics for symptomatic relief. You can also use diazide diuretics. And for systolic or for chronic heart failure, diastolic heart failure, you're basically treating like diabetes, blood pressure. So there's no direct treatments for this, but in systolic heart failure, you can use ACE inhibitors, angiotensin II blockers, beta blockers to decrease mortality. And then for some, you can also use hydralazine and nitrates therapies to not only do symptom control, but also decrease mortality in select patients. So there is another slide that I should have put in here, but I didn't because it's the end of chronic heart failure. There's a bunch of other drugs. But if you're looking for acute heart failure treatments, you want to think of loop diuretics, nitroglycerin, or inotropes. That's just some right off the bat. So I put this in from first aid just to cover that in clinical symptoms, cardiac pump dysfunction, so cardiac output is low, and then you're going to see dyspnea, orthopnea, S3 heart sounds, rails, so all the stuff that we talked about today, just to cover how it happens. So if you get a question and don't see specific things, you could go and answer those specifically. In systolic dysfunction, you're going to see reduced ejection fraction, and your decrease in contractility due to like an ischemia or MI or dilated cardiomyopathy. And the biggest thing I wanted to take from this was here, because I didn't cover many of the other drugs today in my lecture, but you could do ACE inhibitors and angiotensin II receptor blockers for decreasing mortality or spironolactone. And then thiazides or loops are considered for symptomatic relief. And hydralazine and nitrate therapies can both improve symptoms and mortality. So just to complete heart failure, I guess this is the treatments that you can go down. And that is it. Any questions?
Mm-hmm.
Cool.
Well, right on.